Good morning, good afternoon, wherever in the world you are. Welcome to Sensam's webinar about decreasing post-surgical length of stay using minute ventilation monitoring. It's my pleasure to introduce our speaker, Lindsay Holt. Lindsay is an assistant professor in the Sue and Bill Gross School of Nursing at the University of California, Irvine. She has worked as a clinical nurse educator in the perioperative department with over 17 years of experience in the field and holds a BSN from Georgetown University, Master of Science in Nursing, and PhD from the University of San Diego. In this webinar, Lindsay will talk about a quantitative study to assess predictability of minute ventilation to drive safe and timely outpatient discharges of high-risk patients after surgery. After the webinar, we will have some time for Q&A. All participants will be on hold during the webinar. Please post your questions in this chat. Now it's time to hand over to Lindsay. Please enjoy the webinar.
Thank you so much, Kai. My name is Lindsay Holt, as you said, and I'm so excited to be here today to talk about the research that we've been doing with minute ventilation in the postoperative realm. I'm going to start my presentation here. So I just wanted to say that thank you so much to everyone who's invited me to be here, John Paul Pedigo Gomez, George Hamilton, and Mike Gray, for all of their help maintaining and expanding our Expiron program at UC San Diego Health. None of this would be possible without the support of our perioperative department, and that's the nurses, anesthesiologists, nursing leadership, and all supportive members of the team. I know that my background was given to you. Like I said, like they were saying, I've been working in peri-op for the last 14 years, and it's been exciting to see how things have progressed clinically using best practices. So without further ado, I will start my presentation. So again, the research study was decreasing post-surgical length of stay using minute ventilation monitoring. This research was conducted alongside Chris Eldon Newsom and Joanne Dougherty and the entire peri-anesthesia team. Without them, we wouldn't have been able to do this. So this was a quantitative study to assess the predictability of minute ventilation to drive safe and timely outpatient discharges of high-risk patients after surgery. Results showed that minute ventilation was an effective predictor of surgical recovery and inpatient outcomes, and it also improved patient outcomes, evading unnecessary hospital admissions, decreasing costs, and enabling patient flow throughout the hospital. Just a little bit of background, I think as most of us know, surgery and anesthesia are not without risk. These risks are driven by medications administered, type of anesthesia, length of anesthesia, and then also pain control in the recovery room. This drives the recovery time and final disposition, whether that be to an inpatient setting or to a final discharge home as an outpatient. And then these risk factors are further complemented by any of the other comorbidities, like I said earlier. For this presentation, when we talk about high-risk patients, I'm going to be speaking specifically about those that have been diagnosed with or have suspected obstructive sleep apnea, and patients who are obese with a BMI greater than 40 kilograms. So first to talk about OSA. So obstructive sleep apnea is a sleep disordered breathing pattern, and it's hypoxemia that occurs during the REM cycle because of hypotonia or decreased muscle tone, which then causes a narrower collapsible pharyngeal airway. In order to diagnose this, you need a sleep study, and during that study, there needs to be 5 apnea or hypopnea episodes in 1 hour with a decrease of oxygen saturation exceeding 4%. Risk factors for OSA include many things like obesity, biological or assigned sex of being male, older age, menopause, craniofacial anatomy, smoking, alcohol consumption, and family and genetic factors as well. When we talk about obesity, between the years of 2000 and 2017, the CDC said that there was an overall prevalence increase of obesity from 30.5% to 41.9%, and severe obesity increased from 4.7% to 9.2%. Costs related to obesity were upwards of $173 billion, which is actually $1,800 per person higher with anyone who is obese rather than those with a normal weight. Sleep apnea in the obese population looks a little bit different sometimes, and it can be a result of the excess soft pharyngeal tissue that's causing an airway obstruction, which is not related to actual respiratory drive. So I think the first question that we asked when we were looking at this was, what is actually driving the length of stay for high-risk patients post-surgically? Is it the diagnosis? Is it the assessment? Is it the medications? And what exactly are we looking at? So that's how we entered into this study. I want to look at a article that was published in 2022 by the Journal of Sleep Medicine. And here they talked briefly, I just want to show you this to give you an overview of, this is the pre-op algorithm for patients with known or suspected OSA. This is as diagnosed with a stop score of greater than or equal to 3. And the main reason for looking at this is just to show all the thought process and care and planning that goes into these high-risk patients even before they come into the hospital. Looking at the post-operative algorithm for this, I think most importantly to know is that primarily patients are separated into the care categories of known OSA or suspected OSA. The most important part of this algorithm to me and my colleagues were the fact that 3 out of 4 of the decision trees ended with patients being admitted overnight for observation. So again, I think we're asking, why is this and what can we do? So if you look at the research, it shows that these patients with suspected or known OSA, anesthesia medications impede the REM cycle the first 2 nights, actually giving them fewer REM cycles, so less deeper sleep. They actually have less hypopnea or apneic events in those first 2 nights because they don't have this disordered breathing pattern. And then they actually have a rebound of this on nights 3 through 5. These REM cycles are associated with increased sympathetic discharge, which causes tachycardia, hemodynamic instability, and myocardial ischemia. So again, if we're admitting patients for 1 night, what are we doing to help them on 1 night when it's actually nights 3 through 5 that are going to be where they're at their highest risk? When looking at patients with a high BMI, again, I think that this plays into the idea of increased medical costs for a population associated with this diagnosis. If we are not using an assessment and using a diagnosis only, are we actually causing them unnecessary medical costs? Are we preventing these patients from recovering comfortably in their own home? Are we increasing bed scarcity or monitored bed scarcity in the hospital, knowing that these patients will need a minimum of tele with pulse oximetry? And are we impeding the hospital flow in general? Just looking at my hospital historically as I've worked there, when I first became a nurse in the perioperative department, any patient with known or suspected OSA was automatically admitted overnight for observation. As the years went on, we were able to use the research to drive a different discussion, and these patients were then held in the post-operative in the PACU for a longer period of time, a minimum of 2 hours. Then they would be reassessed by anesthesia, and the decision would be made of whether or not they would be able to discharge home or if they would need to be admitted. Again, this leads to lengthy post-operative stays and indecision and confusion of what's going to happen with this patient. Most recently, since we've been able to place the Expiron monitor into this population, we've been able to use the normal discharge criteria that we use for any other patient by means of the Aldrete score, and we're able to discharge these patients in the same time frame as any other patient that has surgery, as long as they have met the criteria, they are safe to go, their pain's been adequately managed, and we have not had any alarms off of the Expiron monitor. So it's been really interesting to see the progression, and it's been really awesome to be a part of it. So here is that OSA stop score that we were talking about. So every patient that comes into the hospital are asked these questions, and from here they are given a score. And in our hospital, our policy is to use a OSA stop score of greater than or equal to 2. If you have that score, then we will deem you as high risk, as having or potentially having obstructive sleep apnea. So looking at different types of monitoring standards, Here we can see that the golden standard is going to be pulse oximetry. This is what we use every day on every patient. It's able to give us reliable data on how the patient is oxygenating. But the drawbacks of this are that patients who are in a decline, you will see a maintained pulse oximetry level higher for longer while they are actually declining. And if they decline quickly, you're not going to see that represented. There's also a difficulty in where the probe has been placed, the color of the patient's skin, as well as the temperature of the skin in order to get an accurate reading. Capnography, another awesome way to monitor how patients are doing, although this shows us hypoventilation and doesn't always show us how the patient is perfusing and oxygenating. And then lastly, it would be the respiratory rate. And here we find that, again, this shows us that ventilation may or may not be happening, although their chest is rising and falling. So it is important to keep all of these in mind. Where minute ventilation comes into play is you have, as you can see on this chart here, you have a real-time decline in minute ventilation, even though there is a delay in the SpO2 or the capnography. So minute ventilation is the respiratory rate multiplied by tidal volume. It is the volume of air that's moving in and out of the lungs with each breath. And minute ventilation is actually able to identify inadequate respiratory function early. And so it is a great indicator of how a person's actually ventilating. So what's the clinical and operational significance of this? We've found that minute ventilation effectively identifies patients at risk for opioid-induced respiratory depression and obstructive breathing patterns. It's the earliest indicator of inadequate respiratory patterns, and it provides additional clinical information to the respiratory assessment. And then we also see that there is a potential improvement in deciding appropriate discharge locations. Currently, these delays in high-risk patients can be as long as or more than 131 minutes. And the goal of our study was to see what minute ventilation would be able to do to decrease that. So our study aim was to determine if there was a difference between the PACU length of stay for patients receiving minute ventilation in their clinical management compared to those who did not receive the minute ventilation monitoring. So again, just for anyone who is not familiar, the minute ventilation monitor is a non-invasive monitoring system that the probes lay across the sternum and on the mid-axillary line. You're able to input some patient information into the monitor, and then it's able to give you their minute ventilation based on their demographics. When we first started this study, we did find that we had some hurdles to overcome. One of the things that we found was that it was really hard for the nurses to document the Expiron data in real time into our Epic charting system. We had heard that they loved the monitor and they used the monitor as far as listening for when the alarms went off, watching it to see how a person was ventilating while the patient was sleeping. But when we went to go check the data, we would find that there'd either be missing data points, no data points, or they would be offset from the vital signs because that was how the nurse was able to have time in their flow to be able to document. With this, we worked really hard with our IT department to try to figure out how we could make this easier for the nurses. We ended up being able to place the Expiron monitors on a capsule, which was then able to slave into the Epic charting automatically, so the nurses didn't have to worry about it anymore. This was a huge step for us because the compliance of using the Expiron monitor went up tremendously. The nurses used it as an assessment tool, and we were able to look at the data to be able to really see what the picture was of the patient's recovery. So for this study, just to go over the inclusion criteria, we used patients that were greater than 18 years old. They had to be diagnosed with OSA or be at high risk of OSA as defined by that STOP score greater than equal to 2, or have a BMI greater than or than equal to 40. UCSD has 5 different operating rooms. We used 2 of the main operating rooms in the hospital, the one that was on the La Jolla campus and the one downtown in San Diego at Hillcrest. Exclusion criteria for this study was any patient that was diagnosed with other respiratory disorders, a patient that came out of the operating room or that was already and still intubated, and patients requiring an extended length of stay for reasons unrelated to oxygenation. Our control group was a retrospective review of 50 high-risk patients that used our previous standard of care, which was respiratory rate, heart rate, pulse oximetry, capnography. And we compared that to our intervention group, which was 50 high-risk patients that was the standard of care plus minute ventilation monitoring using the same data points. So initially, when we first looked at the data, we did see that out of the patients that we saw, any patient in the control group, wherever their final destination was decided, and that's where that patient went. We found that after using the minute ventilation monitoring, we were able to find a few patients that were slated to be discharged home that were not ventilating appropriately that needed to be admitted. And then on the flip side, we also found patients that were slated to stay overnight for observation that were actually able to go home. Looking at the minutes themselves, I have it split here on the left side by hospital, so you can see the decrease in minutes after to discharge. So this is time of recovery to discharge at the La Jolla location and the Hillcrest location. And then you see on the right-hand side is the total minutes that were decreased in the length of stay. And you can see it's almost 2,000 minutes for these 50 individuals. So what does that translate to? And I think that we can all see the financial impacts that these have, that this has the potential to have. So when you stay in the recovery room, so the operating room and the recovery room both have a $ per minute rate that the patients are charged based on their acuity level. We used an average acuity level of 3. It goes on a scale from 1 to 4. Most people who are intubated, who are high risk, are going to come out at least a 3, and that's 45 minutes an hour. Using that number, we were able to say that those 2,000 minutes, or almost 2,000 minutes, equated to an $88,000 worth of savings as far as the minute stays in the recovery room. Now, what this doesn't cover is the minutes that were any kind of delayed minutes in the operating room, the nursing care that was provided, and the cost of those nurses to be there at the bedside to take care of these patients, et cetera. So you can see it was a huge impact. So what happens? So the patient's saving money, right? Because they're having a shorter recovery time. They're avoiding the hospitalization for admission for observation. The hospital then is able to increase efficiency. So as I stated earlier, it decreases operating room hold time because if there's too many patients in the PACU, they can't move the patients out of the operating room. And in those cases, the patients are charged more money per minute because they're in the operating room under the care of anesthesia. It decreases operating room start time delays if we can keep the flow, and it allows for bed availability for patients outside of the hospital that may need a bed that are coming in through the ED, through facility transfers. And then it increases specifically monitored bed availability, which is, we all know, pretty scarce right now, knowing that these patients would take a monitored as a tele or IMU level of care. And then our staffing model improves as well, because nurses are able to care for their other patients. Another important note of this study was that all the patients that were discharged home quicker and were able to avoid that hospitalization for observation, none of these patients were readmitted to the hospital for a respiratory event, and all the patients remained safe after their discharge. So it was excellent on all realms. So again, just looking at the STOP score, I just wanted to visit it again just to show you how these things have driven our policies and guidelines at the hospital. So again, this is the STOP score that we use to deem whether a person is high risk or not. From here, we have our OSA documentation. So this is how it translates into EPIC, showing us that score. So you can see here where the questionnaire is. It's not a direct yes, yes, gets you a 2, but you do see there is an algorithm to decide what the risk score is. For the PACU OSA discharge assessment, so we use this information to drive how we discharge patients who have OSA. The thing about this is that we were able to update this to include minute ventilation monitoring as a criteria of how we decide whether a patient is going to be admitted or discharged. And I mean Expiron or minute ventilation in the sense of high-risk patients are placed on the minute ventilation, and from there we need to be sure that we see a less than 30 minutes or more of no decrease in their ventilatory status. Now, based on the levels of that they fall into. This is given their OSA score, how much narcotic they require, what happens with the Expiron monitor. It then dictates whether or not the patient is able to go home or not. Another point historically is that any patient with suspected or known OSA had to be seen by an anesthesiologist prior to being discharged out of the hospital for the final okay. We've now deemed it to the fact that we have come to a place where the patients are safe, and it is the nursing discretion based off of these discharge assessments and criteria that they can then say, okay, you met these criteria, you're okay to go home. If in turn it seems like maybe the patient would do better staying longer in the recovery room or needing a room overnight, again, that is a welcome conversation with the anesthesiology team. So we've also incorporated a Expiron monitoring guideline into our hospital. This shows who's ordered it, how it's ordered, when it's ordered, and how we monitor the patients. We built an Expiron order into our PACU order set. So once the patient, if it's a known or suspected OSA or meets any of the other criteria, anesthesia can check the box and the order comes up automatically. What we also did find was that nurses were asking for the Expiron monitor on patients who maybe hadn't been deemed high risk to start, but were potentially struggling in the recovery room. And for this, we created then a standalone Expiron monitor order so that any patient at any time could be ordered the Expiron, and we would be able to place it on them. Again, looking at our discharge policy, we again incorporated the Expiron monitor into this policy, where we discuss that there needs to be an absence of decrease in ventilation for 30 minutes, that the patient is otherwise safe to go home and has met all discharge criteria. So what are the future implications of this? So we have applied for the 2023 ANCC Magnet Prize. We have asked to see if we could expand our Expiron monitoring to interventional radiology to help drive moderate sedation in these procedures and a quicker recovery. And then talking about moderate sedation procedures to also then expand it to interventional pulmonology, gastroenterology. We're working in collaboration with the ICU and the emergency room to, again, incorporate Expiron into bedside sedation procedures, and then as well as extubation protocols to be able to monitor minute ventilation during and after extubation. And then lastly, we're working with our psychiatry and ECT programs, again, as a moderate sedation procedure to help drive the medications administered. So just lastly, I think talking once again about how can we change this conversation and how can we use the data to drive decision-making as far as patients' length of stays and where they will be most comfortable and most safe on their discharge home. And again, just the other points of improving the hospital flow, improving patient satisfaction, and ensuring that all the patients are safe.